And I'm very happy to be here with you for this very important congress. It's the first one dedicated to bringing together the patient and the medical community. I think that we have to learn for each other, and it's very important. And I will talk today about a very important question: how to reduce time to diagnosis in 2024. So you probably heard before, or you experienced the fact that sometimes to diagnose AL amyloidosis, from the onset of the symptoms and the diagnosis, it could take for a significant number of patients several months, even several years. And I put here some results of the literature, but there is a lot of articles demonstrating that. You can see here that only 28% of the patients are diagnosed before 6 months after the onset of the symptoms. For other 28% of the patient, it will be between 6 months and 1 year after the onset of the symptoms, for about 20% after 1 year, and even for the last 20% of the patient after 2 years and even 3 years after the onset of the symptoms. And so it's very important, this topic. And you can see also here from in another article, it's the number of doctors that the patient has to see before the diagnosis. Sometimes it's about 4-5 different doctors. Usually the first doctor is the primary care physician, and then the patient is referred to the cardiologist, the nephrologist, or the gastroenterologist or the neurologist. And why could it take so long to give a diagnosis in disease? Probably because this disease could affect all the organs except the brain. And we call this disease sometimes the great imitator. Why? Because it will give a lot of different specific symptoms, and we will come back to those symptoms later in the meeting. But those symptoms can mimic a lot of different diseases. So sometimes it's difficult to think about a rare disease when you have a lot of other diseases that could give also those symptoms. And why is so important to pose diagnosis earlier after the onset of the disease? What you can see here, it's what we called a survival curve. So at the beginning, all the patients are in life, and there you are losing patients usually from the involvement organ. You can see here the curve of survival of the patient who are diagnosed before 6 months after the onset of the treatment. And you have a better prognosis if the diagnosis is done earlier in the course of the disease. And why? Because in fact, when you are waiting too long, there will be more advanced organ involvement. And we know that in AL amyloidosis, the two most frequent organs that will be damaged are the heart and the kidney. And in fact, when the patient arrives with severe cardiac dysfunction, that affects very importantly the prognostic of the patient. You can see here, it's again a curve of survival. So you diagnose here the patient, and here is the curve for the patient with very severe heart disease. And you can see that we are losing a lot of patients just after the diagnosis, just because of early cardiac event. Those patients can do important cardiac complications. So it's very important to pose the diagnosis earlier. And in 2024, of course, course, we have new treatment, and you will heard during the Congress about daratumumab, an antibody that targets the plasma cells, the white cells that are responsible to the production of this abnormal antibody that will give the amyloid fibril. And you can see if we are comparing this curve, they are with the treatment with daratumumab, they are very, very better than the historical curve. So we are improving the prognostic of the patient. But still, if you are taking a look to the patient with severe cardiac damage, you can see that those patients still have it's the mortality coming from cardiac events due to the cardiac disease. And you can see, okay, we are doing really better with the new treatment, but still, if there is a long time between the onset of the symptoms and the diagnosis, there will be patients with severe cardiac disease and patients with a risk of more than 20% of early mortality due to cardiac damage. So it's very important. And it's not only important for the survival and the prognostic of the patient, it's also important for the quality of life. In fact, when the patients are coming with the diagnosis of AL amyloidosis, sometimes they have a lot of symptoms that could affect the physical functioning, but also the social functioning and the emotional well-being, and also the sleep. And sleep is very important for the quality of life. And the symptoms will be more important if the disease is more advanced, and even if with the treatment the patient is complete remission, sometimes the patient will still have important symptoms. And if you are doing the diagnosis earlier, you have better chance to have lower symptoms and to decrease those symptoms with the treatment and have a better quality of life. So how to improve? But we can start from the symptoms. Some symptoms are very pathognomonic. You will see those symptoms only in AL amyloidosis. But if we are seeing patients with those symptoms, it's too late. Everybody will think about AL amyloidosis, but it's too late. We have to think before those symptoms. And then how can we do that? We have to give information, seminars to the doctor that will see first those patients. So the general practitioner, the primary care physician, the cardiologist, the nephrologist, and the gastroenterologist. And we know that it could work because we are seeing that with the reimbursement of the new treatment in the another type of amyloidosis, transthyretin amyloidosis, cardiologists are diagnosing now more amyloidosis and also more AL amyloidosis. And we have to inform those patients about red flags warning. When do you have to think about AL amyloidosis or another type of amyloidosis? Sometimes those symptoms are very specific, such as persistent and unexplained fatigue. And we know that a lot of people have fatigue, but if they are persistent and the patient come and say, okay, something is wrong with me, we have to listen to the patient. Weight loss, swelling, edema, particularly in the legs, numbness and tinglings in the hands and the feet, shortness of breath, change in the bowel habits, easy burning, and when you are doing the physical examination of the patient, an enlarged liver, enlarged tongue, what we will see that carpal tunnel syndrome, lower tension with that could increase with the postural position, and also bleeding tendency. And what's more important is when the patient is coming with more than one symptoms, and when those symptoms are linked to an abnormal protein, a monoclonal protein in the blood. Then you must think about this. The doctor must think about this disease. And we know that the two most involved organs are heart and kidney. So now the cardiologists have better imaging technique to detect those diseases, and even sometime on electrocardiogram they can think about this disease. We have also to inform the nephrologist and the general practitioner when you have protein in the urine and a special protein albuminuria, or sometimes a huge amount of those protein, what we are calling nephrotic syndromes with edema. And without other causes of this protein in the urine, such as diabetes, you should think about and search the AL amyloidosis. And of course, when there is cardiac symptoms and protein in the urine, that's a very super red flags for the doctor. There is some symptoms that are very common in the general population, such as carpal tunnel, that are giving pain and numbness in the first fingers of the hand due to the compression of the median nerve in the wrist. And we know that those symptoms could also be seen in the AL amyloidosis, but also in the other type, one of another frequent type of amyloidosis, transthyretin, coming from another protein secreted by the liver. And what we could also do is to inform the surgeon that if you are doing a surgery for this carpal tunnel symptom and the patient is older or with a monoclonal protein or with other symptoms, just do a biopsy and send this biopsy to research if there is protein of amyloidosis in the tissue. And there is a publication showing that sometimes you can find about 20% of the patient with amyloid deposit on this biopsy. So it's a simpler way to decrease the time between the onset of the symptoms and the diagnosis, and we know that often these symptoms occurs before the cardiac involvement. So hematologists have also to follow the patient with what we call a monoclonal gammopathy of indeterminate significant closely. Each year we are following those patients. Those patients have a monoclonal protein in the serum, and without disease associated to this monoclonal protein. It's very frequent in the general population. From the age of 50 years old, you can have 3% of the general population with this abnormal protein in the blood without disease. But when you are seeing those patients, you have to ask the specific question to be sure that there is not early symptom that could suggest that there is a begin disease, AL amyloidosis disease. And we have also each year to search biological markers of cardiac, kidney, or liver involvement. Sometimes delayed is not only due to delayed in the diagnosis and to think about the diagnosis, but it's also due to a misdiagnosis. I think that my colleagues will speak about that. Why? It's because that are the two most frequent amyloidoses. And you know that AL amyloidosis is coming from a monoclonal protein, that this monoclonal protein is frequent in the more older people, but the other disease, the other amyloidosis is also more frequent and increasing with age. So sometimes you can think that patients have one type of amyloidosis, and if the patient have transthyretin amyloidosis with a monoclonal protein, sometimes there is a misdiagnosis because you are seeing a monoclonal protein and you are thinking that it's an AL amyloidosis. So what can help? as always, the symptoms, some are more specific of AL amyloidosis, some more from transthyretin. I will not go on this, but you will see in the next presentation that we have cardiologists have no very good imaging scintigraphy to see the captation on the heart, and if there is no monoclonal protein, you could be sure that there is no AL amyloidosis, and that is a transthyretin amyloidosis. And of course, we need good pathologists to analyze this disease. And can we do something more in 2024? So we are getting to know better and better this complex formation of, you can see it's very complex. You have the mutation, different misfolding of the protein, and we are beginning to have more information about that. What we know, it's when there is glycosylation. Glycosylation, it's meaning that you are adding sugar to the small part of sugar to the protein. There is a higher risk to develop AL amyloidosis when you have these simple abnormalities in the blood, the monoclonal protein. And here it's a study following patients with this gammopathy, monoclonal gammopathy of unknown significance. And you can see that the patient without glycosylation of the monoclonal protein, there is only after 25 years 3% of patients with AL amyloidosis, and it's a little bit more than 20% when you have this glycosylation. So this test is not available in routine in the majority of the center, but in the future it could help us. And there is a great evolution of the test. Now, in some centers, it's not in routine. There is mass spectrometry. You can detect low level of light chain, monoclonal light chain, and also the specific glycosylation. And we heard during the last Congress at the ISA Congress that there is new test that maybe tomorrow will permit to detect patients with AL amyloidosis. So in the future, it will probably help us to detect earlier this disease. So to conclude, what is important? I think that today, the most important is still the information of the doctor, all the specialty, and to listen to the patient. We are seeing with the testimonies that sometimes the patient are saying, hey, something is wrong with me. I came 3 times and now you have to listen to me. So that's the most important point. Give information, listen to the patient. Then in the specialized center, you have to have a fast track to care rapidly the patient and give rapidly the treatment. You have to follow with the MGUS patient with the questions and the test to detect early the possibility of AL amyloidosis. Of course, we have to use the new technology, and in the future we will have more and more access to the new technologies. And maybe we heard it's too early to have to speak about that, but there is some early report about artificial intelligence. Maybe tomorrow it will also help us. Thank you for your attention. I think it will